All right. So as Miguel said, I'm going to tackle sort of the opposite problem that he was thinking about. I'm going to start by assuming away all of the problems that we've been talking about all day today about confounding, unmeasured confounding in observational studies, and as Miguel said, the unmeasured confounding in randomized studies after the randomization occurs. But before I do, I always forget this. I want to acknowledge that a lot of the work that I've done in this area was jointly with my colleagues Joel Greenhouse and Howard Seltman at Carnegie Mellon, and Drs. Kelleher, Gardner, and Stevens at Nationwide Children's Hospital in Columbus. So I'm going to start by agreeing with Miguel also that the terms efficacy and effectiveness are very vague. But I do think that they're useful in sort of classifying the kinds of things that we want to be thinking about when we're designing our analyses. So I'm going to be focusing on the population issue in terms of what population do we actually want to make inference about. And so in the development setting, we would use the term efficacy to be thinking about defining the population of the best individuals, because we want our trials to be very cost efficient and to show a positive treatment effect if one exists for anybody. So we often use these enrichment designs that recruit patients that are likely to experience the largest possible treatment effects and who will be cost efficient from the standpoint of complying with the trial. And we also want to avoid recruiting people who we think will be harmed by the treatment. So these are all things that are shrinking down the population that we're actually studying in these typical randomized trial. In the policy setting, however, we want to be doing something totally different. We want to be thinking about what is the average treatment effect for the population of interest, or for perhaps some subpopulation of interest, or we can shrink that subpopulation down very, very small to personalized medicine and sort of think, well, what would be the average treatment effect for a sample size of 1? And so the question that I want to address today is, can we generalize information from studies designed to evaluate efficacy to inform effectiveness? Again, just focusing on the population issues. I think all of the other issues can be included, but I don't want to complicate matters by considering them here. So in order to do this, I want to be very clear about what the population is. So I'm going to be talking about two populations. First is the target population, and I think of that as the population of all the individuals for whom treatment may be considered for its intended purpose. So I don't want to get into off-label things or in purposes for which the treatment wasn't intended. But I think we all could agree that that is likely to be somehow different from the trial population, which is difficult to define. So for now, I'm going to think about the trial population as the theoretical population that consists of all the individuals who would be eligible to enroll in the randomized controlled trial. So one might argue that this is the population that is directly generalizable from the randomized controlled trial. And so the question is, if we can define or model how the trial population relates to the target population, then we would know how to go about generalizing. And so we could think about a number of different ways that we might relate the two populations. The first is the best case scenario. If we could manage to convince ourselves that the trial population was a simple random sample from the target population, then we'd be golden. We would be done. If this was the case, we would see some evidence, like the distribution of the baseline variables should be identical between the two populations. And so we can look for discrepancies or evidence against this simple random sample idea by looking at the distribution of the baseline variables in the trial participants and comparing those with the distribution of baseline variables in a representative sample from the target population. And we could obtain that representative sample either from administrative sources or from survey sources. There's lots of ways we could get observational data to do those comparisons. If we had a simple random sample, we also would expect that the outcome variables should be at least logically related. So we don't expect the distribution of treatment to be the same in the two populations, because obviously we're assigning treatment in the trial. And so we wouldn't expect those distributions to be identical, but we should expect them to be at least logically related. So the example that I give is we were looking at the issue of suicidality in antidepressant randomized controlled trials. I'm sure you've all heard about that. And we compared the rates of suicidality that were observed in those trials to the rates that were observed in the Youth Risk Behavior Survey. I should mention this was just for adolescents, so we were only looking at the youths. And so the results from the trials suggested that taking antidepressants was a risk for increased rates of suicidality. And so among the trials, it was reasonable to assume that, well, we thought it was reasonable to assume that more of those patients or more of those subjects would be taking antidepressants than in the population at large. And so we should observe a higher rate of suicidality in the trials as compared to the observational data. When we looked at the data, we did not see that. And so this was one example of us arguing that we can't be treating the trial population as a simple random sample from the target population. So if we don't have a simple random sample, the next sort of more complicated thing we might think about is a weighted sample. So the idea is that you have representative people in your trial population that can represent those in the target population. We just have the wrong proportion of them. And so we could just simply use already known weighting schemes to reweight our trial population or our trial sample so that we can generalize the results to the treatment or the target population. And so examples of that would be using probability sample methods out of the survey sampling research, like post-stratification, or you can start looking at propensity-based standardization that Elizabeth Stewart has done a lot of work on. However, we all know, we started this session talking about how we recruit patients into trials not at all like a weighted random sample. We have lots of inclusion and exclusion criteria, and lots of people have looked at the impact of inclusion and exclusion from the standpoint of how big might this problem be. So lots of people have shown that it's usual for the trial population to represent less than half of the target population. So that's well known. But there's been very little work to answer the question of, well, do we care? Are these exclusions important? So should we be worried about generalizing these particular results to the target population? So essentially what we're talking about is extrapolating. So we would like to reweight and interpolate as much as we can, but once we go outside of the population that we know about, it is essentially extrapolating. And so we can do a number of different things. We could think about sensitivity analyses. So we know how big the size of that unrepresented population is. How big must its effect size be to reverse the results that we were observing in the randomized trial? If that effect size would be really unreasonable, then we can be more comfortable in generalizing the results, at least in the same direction for the target population. The other thing that we can do, and we've seen examples of that today, is compare randomized trial data to parallel observational studies. And the way these are often considered is creating a registry at the same time as the trial is designed to follow up and take measurements on those patients who either were not eligible for or opted out of that trial. And so you can think about comparing the trial data directly to the results in the population that wasn't eligible to be enrolled. It's an interesting problem that Sue Marcus has been working on. It's a little bit tricky to do because, of course, you're then confounding the problems of comparing the design and comparing the population. So that's a little bit harder to do. Another thing that I would advocate that we should think about is applying the exclusion criteria to data representative of the target population. And this is based on the cross-design synthesis framework that the GAO proposed in 1992. And more recently, we've been looking at the more technical properties of. So I just want to give you a big picture idea of what this framework would look like. So the framework idea is that you want to stratify the target population by those represented by the trial and those not represented by the trial. And in terms of the evidence that we have, we can use the randomized data to hopefully make good inference about those represented by the randomized trial. So in this sort of square there. And we can also, as we've been talking about all day, use observational data to hopefully make good inference about that same population. So this is the included population. And so this is what Miguel was talking about. We should be able to compare these two. I would argue, though, that the effect size in the excluded population, though, is also important and we should think about. And so what we're going to do, or what I would advocate doing, is looking at the observational data, looking to the observational data to see how big of an effect there is due to the exclusion or the differences in the populations. And so we can compare the effect sizes estimated from the observational data to make inference about how comfortable we should be about generalizing the data. There are, of course, some limitations of this approach. One is that the overarching idea is that you have to sort of buy into the idea that we should be modeling here. So we do need to do this based on models. The other thing is that you need fairly special data in the sense that you need, for your observational data, you need to know about the treatment, you need to know about the outcome, and you need to know about the exclusion criteria. So this, of course, would be very difficult to do before a treatment is accepted in the population. But in the context of, say, phase 4 explorations, this is something that I think we should be doing to promote our learning healthcare environment. Is that our buzzword? The other thing is that in order for this to work, we need to also be thinking in the background about the limitations of the observational data. And again, I don't want to get into the details of this, but if we are able to use all of our fabulous statistical methods to get rid of confounding within these subpopulations, obviously this comparison would make a lot of sense. In this framework, though, we get the bonus of being able to relax that requirement just a little bit to say that as long as any residual confounding is separate from the exclusion criteria or is separate from how we're defining the stratification, then the bias would be linear and would subtract off. So this is a little bit specialized, but it's a little bit more relaxed than the usual requirements for observational data analysis. And so I just want to show a quick sort of toy example of what this looks like. So this is looking at a study that was done to assess the efficacy or the treatment effect of using an insulin pump as opposed to insulin injections. And the outcome that was considered is the change in A1C, which we all know now is not the best outcome. But the problem in the trial design is that you really want to only recruit patients who are going to be very compliant, especially with the injection arm of the trial. And so patients for this particular trial were only recruited if they were very good at regularly monitoring their blood glucose. That's what I mean by the greater than 4 checks. So in the randomized trial, we found that, of course, there is a positive treatment effect in the sense that we reduced the A1C by almost 1. But then if we look in the observational data set, or a parallel observational data set, we see that in the observational data, we see a much smaller effect size. And that could be for a number of reasons that have to do with how to analyze the observational data, or perhaps the environment that the treatment was studied in. But what we can see is that if you think about the people who are not so good at monitoring their blood glucose regularly, those are the ones for whom we would expect these pumps to do much better, because part of the point of the pump is that it's doing some of that monitoring for you. And so by comparing the outcomes in the two strata for the observational data, we can think about generalizing from the randomized control trial that if we could implement this very controlled environment and answer the right question, then the randomized control trial is probably actually underestimating the average effect size in the larger population, something that would be probably of much interest to insurance companies who may be more willing to pay for this. So I want to finish up by saying that this is very preliminary work. It's a very simplistic setting. There hasn't been a whole lot of development in this area. And so I want to say that there's lots of extensions that we could think about that would make these models more realistic. I want to emphasize that what we really want to be doing when we're thinking about synthesizing across types of data is looking at all the available evidence and looking to make sure that the inference is consistent or explainable. And so we also want to be thinking about multiple treatments. And finally, I want to mention that this stratification is very much an artifact of believing that the people who are in the trial represent everyone in that population who would be eligible. And this, of course, is a little bit naive in that patients also opt out of the trial for various reasons that we certainly can't define a priori. And so it would also be important to start thinking about how to capture that. And my thoughts about how to do that is to start to think about population membership as more fuzzy or soft classification. And that's what I have.